Hello, one and all. Myself, Kirti Patil, occupational therapist from KM Hospital. Today, we'll be discussing about hemophilia and occupational therapy management. So, first, let's understand what is hemophilia. Hemophilia is an X-linked heritable coagulopathy with an overall prevalence of approximately 1 in 10,000 individual. So, the most common form is factor VIII deficiency or hemophilia A, which compromises approximately 80% of the cases, and factor IX deficiency or hemophilia B, which compromises approximately 20%. Depending upon the severity of the disease, based on the factor levels, the bleeding episodes are frequent and spontaneous in severe hemophilia, which is less than 1%, or occur mostly after minor trauma in moderate hemophilia, that is 1 to 5%. In a patient with mild hemophilia, which is 5 to 40%, bleeding usually occurs only with major trauma or surgery. But the joint damage occurs progressively in patients with hemophilia, leading to functional decline and disability. So, mostly this bleeding occurs in the knee, elbows, and ankle joint, and it is often evident from the early childhood. In patient with hemophilia, regular replacement therapy with concentrate clotting factors is effective in preventing recurrent bleeding episode in joints and muscles. However, this success bleeding most commonly occurs in knee, elbows, and ankle and is often evident from early childhood. So, the most target joints are the ankle joints, elbow joints, and the knee joint. And the muscle which are mostly affected are iliopsoas muscle, the forearm muscle, and the calf muscle. Patient with hemophilia, regular factor corrections or clotting factor concentrates, that is a prophylaxis or on-demand therapy, is effective in preventing recurrent bleeding episodes, mostly in the joints and the muscles. However, despite this success, intra-articular and intramuscular bleeding is still a major clinical manifestation of the disease. Recurrent joint bleed causes synovial proliferation and inflammation, that is a hemophilic synovitis that contribute to end-stage degeneration, which is called as hemophilic arthropathy, with pain and limitation of motion severely affecting the patient's quality of life. So here you can see if there is a bleed, then there is a deterioration of the joint surfaces which causes the synovitis. Again, there is a pain, and because of the pain, the patient always keep the limbs in the resting position. Due to the continuous resting position, there is a reduced activity, reduced fitness, and When in such situation, if he is not mobilizing his joints, returning to the activities may again cause a bleed. So this is like a chain reaction which happens in every PWH. So now we have to understand why movement and exercise is important in hemophilia. See, whenever the patient is off bleed period and he is doing a regular mobilization, he is on a regular mobilization protocol. The strong muscles and good flexibility and coordination of the reflexes. So every after each and every bleed, there is a quicker recovery. There is a fewer target joints form. There is a normal healthy lifestyle, decreased in the joint bleeds, and definitely because of all this, there is a continuation of schooling, continuation of the uh, jobs where the patient is going. He gain good confidence for that. So now we have to understand what is the goals and aims of the occupational therapist in hemophilia. First and foremost goal is relief from the pain. Once the pain is relieved, we can work on the prevention of deformity. We have to preservation of the joint function, return to maximal function with full range of motion, return to maximum strength with normal muscle length. Of course, keeping all this in mind, the first and foremost goal should be prevention of a bleed or a recurrence of a bleed. And this all leads to facilitating independence in ADL work and leisure activity. So to begin with, we have to first start with the clinical examination. Whenever we are doing a clinical examination in any hemophilic patient, we have to consider primary and secondary examination. So regularly what we do in our clinical places or clinics, that is the primary evaluation, taking the history, inspecting the joint for swelling, wasting, pain, crepitus, doing the goniometry for a range of motion, assessing the pain through visual analog scale, doing the muscle strengthening sensation. Two major scale which we use for hemophilia is HJHS, that is the Hemophilia Joint Health Score, and FISH, that is the Functional Independence Score for hemophilics. Along with that, we do the gait analysis, posture coordination, and overall fitness. We have to keep in mind that HJHS and FISH has to be done 6 weeks post bleed. There should not be any acute bleed during doing the HJHS. Again, very important is the secondary clinical examination. We have to keep a record of number of bleeds, number of infusions taken, development of any target joints, inhibitor, and any other complications. So this is the sheet of HJHS score. Here, if you can see, mainly elbow, knee, and ankle, the target joints are considered. If at all you feel there is any other joint which is involved, then you can do your regular goniometry and keep a record of it. But because these three joints are the most commonly affected, we do the HJHS in hemophilia. Maximum score is 124, and you have to, this has to be done on a regular intervals. At our centers, we do HJHS score on prophylaxis patient every 6 monthly, and for any other on demand patient, whoever is coming to our center, we do the HJHS score post bleed 6 weeks. So now we will see, these are the, we will talk about the joint bleeds. So mostly commonly affected joints are knee, elbow, and ankle. Here you can see there is a triple deformity. Here one of the patient had joint triple deformity. So now we will be talking about the joint bleeds, and the most commonly affected joints are knee, elbow, and ankle. So a joint bleed is defined as an episode characterized by rapid loss of range of motion as compared with the baseline that is associated with any of the combination of the following, like pain, unusual sensation in the joint, swelling, warmth over the skin. In children with severe hemophilia, the first spontaneous hemarthrosis typically occurs before 2 years of age, but may occur later also. If inadequately treated, repeated bleeding will lead to a progressive deterioration of the joint and the muscles. So, this will lead to a severe loss of function due to joint deformity, loss of motion, muscle atrophy, and contracture within the first 1 or 2 decades of life. The origin of the synovium, very early bleeding in joints may be recognized by the person experiencing it as a tingling sensation and tightness in the joint. So, we always ask the patient if he feels any aura before the bleed, because as early as the factor is taken, icing is done, resting is given, we can avoid any major kind of bleed. So, this aura precedes the actual occurrence of the clinical features of acute hemarthrosis, that is the pain, swelling, limitation of motion. Once blood fills the joint cavity, the joint will appear swollen and feel warm and tender. This will cause the joint to seek the most comfortable position, of course, which is the flexion for any joint. So, any attempt to change this position causes more pain, thus limiting motion. Also, there will be secondary muscle spasm that follows as the patient tries to prevent any motion. Uh, Even after factor correction, there are episodes of rebleed which is which worsen the condition and which may cause within 72 hours after stopping the treatment. So now first let us understand what is a target joint. So a target joint is defined a joint in which there are 3 or more spontaneous bleed that have occurred within a consecutive period of 6 months. So most of the target joints are ankle, knee and elbow. So I'll just give you a brief guidelines for the management of acute hemarthrosis. So the most important initial step in management of an acute hemarthrosis is of course factor replacement as soon as possible at a level sufficiently high to stop the bleeding. Ideally, the most effective method of providing immediate factor replacement is to have a home therapy program in place that allowed the informed patient with hemophilia to give the factor at an appropriate time. At our center, we start with day 1 with the rise, that is resting, icing, compression, elevation and exercises. So rest is the position of comfort. Immobilizing, that is partially or temporary with splint, pillows, sling and crutches depending upon the joint which is affected. Ice pack can be applied immediately for 20 minutes and can be repeated every 2 hourly for at least the first 12 hours. Ice should not be in direct contact with the skin. Elevation of the affected joints has to be advised and tolerable pressure bandage can be used. Exercise must be stressed on the active part of the management of acute joint bleeding episodes, which should include that as soon as the pain and the swelling begin to subside, the patient should attempt to change the position of the affected joint from a position of comfort to the position of function. So initially when we start giving, when the factor concentrates are being given, we have started giving him icing, have given him a splintage for resting and along with that compression. Gradually you start with the active mobilization, so that we are decreasing the flexion on the joint and striving for complete extension. Start with gentle passive stretching and more importantly active muscle contraction to gain extension. As soon as the joint is in the position of function, the active muscle exercise, proprioceptive training must be started and continued until complete pre-bleed joint range of motion and functioning are restored and the sign of acute synovitis has dissipated. So we will talk about how we can. So this was the management of target joint or any knee, any joint bleed. But first and foremost, our aim should be for the prevention of target joint. So how we can do it? We have to see to it that we are minimizing the risk of developing chronic synovitis. So when the patient is in off bleed phase, regular exercises has to be done. Along with the patient, his family has to be educated about the importance of exercise, importance of taking factor on time, and showing to the clinician every 3 monthly. He should be educated about identifying early bleeds. He should be educated about rise and should be able to be identify the bleed as early as possible. Protection of the joint methods to protect the joint has to be explained, like the rest, what modification has to be done. We have to give him some protective cuffs, mostly to the kids who school going kids and adults who are on computer for a longer time. We have to explain them the importance of wearing protective cuffs. We have to restore the range, strength, proprioception of the joint to the pre-bleeding level as soon as possible after each and every bleed. And very important, early aggressive management and adequate post-bleed rehabilitation of all bleeds has to be delayed and even prevented so that the bleed synovitis bleed cycle which characterize the target joint can be avoided. So these are some of the splints we make at our center. This is the serial static correction splint we use for triple deformity. Static progressive splint for knee flexion deformity. You can see gradually the corrections has been made. There is a component in which the splint is gradually increase where we gradually increase the angle of the splint. Again, correcting the elbow deformity using low cost serial static splint. So now we have to be very much clear what intervention we are going to select for the given patient, whether it would be operative or non-operative. How we are going to decide about it. So if a patient comes to you with a flexion contracture up to 60 degrees and there is no involvement of any other joint, there is a reasonable end field. And if you have been giving him traction, splintage, regular mobilization along with prophylaxis, if available, and if you see an improvement of at least 5 degrees a week or 10 degrees in 2 weeks, then that kind of patient can be considered for a non-operative treatment. On the other hand, if there is a flexion deformity of more than 60 degrees after failure of conservative methods for at least 2 weeks, then we can opt for a surgical intervention. There are procedures depending upon the specific condition needing correction. So there are few procedures which we do. One is extraarticular soft tissue release to treat the contracture. This is called arthroscopy to release the intraarticular adhesions and correct impingement. Elbow sinectomy with radial head excision can be done. Osteotomy to correct an angular deformity is been done. Prosthetic joint replacement for severe disease involving a major joint, mainly knee, hip, shoulder, elbow. and arthrodesis of the ankle, which provides excellent pain relief and correction of the deformity with the marked improvement of the function is been done it at our center. So now we'll talk about chronic synovitis. Chronic synovitis is usually seen in the first and the second decade of the life. With repeated bleeding in the joint, the synovium becomes chronically inflamed and eventually it hypertrophies, causing the joint to appear grossly swollen. You can also see the muscle atrophy and a good range of motion is preserved. But the most muscle atrophy is often present while the range of motion is mostly unaffected. Diagnosis can be performed by detailed physical examination of the joint, and presence of synovial hypertrophy can be confirmed by either ultrasonography or an MRI. So let us talk about the guidelines for synovitis management. Factor concentrate replacement ideally should be given with the frequency and dose level sufficient to prevent recurrent bleeding. If concentrates are available in sufficient doses, then short treatment courses like prophylaxis for 1.5 week of, can be given with intensive exercise. Intraarticular injection of long-acting steroids in advanced stage of synovitis can be considered. In exercises, we have to make it sure that he is doing a regular exercise to improve muscle strength and maintain joint motion. Modalities can be used to reduce secondary inflammation if needed. Functional bracing, which allows the joint to move with ability to prevent new bleeding, can be advised, and functional training has to be initiated. If the synovitis is still not resolved, then we can consider synovectomy. So, in synovectomy should be considered if chronic synovitis persists with frequent recurrent bleed not controlled by other means. And the option for the synovectomy are the non-surgical, that is the medical synovectomy, and surgical synovectomy. In non-surgical synovectomy should be the procedure of choice for treatment of chronic hemophilic synovitis, which can be radiosynovectomy or chemical synovectomy. So to conclude on management of target joint, whenever there is an acute hemarthrosis, exercise along with prophylaxis is available, can be considered. When it goes into a chronic synovitis, prophylaxis or radioactive synovectomy along with splint and exercises can be considered. And when it goes into an arthropathy, joint protection measure, exercise, pain management has to be considered, followed by elective surgeries. Now let's talk about muscle hematoma. So muscle bleed is defined as an episode of bleeding into a muscle determined clinically by symptoms like pain or swelling and functional impairment. Most critical sites of bleeding are those that have a risk of compromising the neurovascular function, which includes the iliopsoas muscle, which may cause the femoral nerve palsy, gastrocnemius muscle, which causes posterior tibial nerve injury and muscle contracture leading to equinus deformity, flexor group of forearm muscles causing Volkmann ischemic contracture. The symptoms of muscle bleeds include aching in the muscle, severe pain if muscle is stretched, maintenance of the limb in a position of comfort, tension and tenderness upon palpation. So early identification and proper management of the muscle bleeds are very important so that we prevent the permanent contractures, rebleed and formation of pseudotumors. So these are the common muscle hematoma: iliopsoas muscle, forearm muscle, gastrocnemius muscle bleed. This is the presentation for iliopsoas muscle bleed. So for the management of muscle bleed, thorough clinical evaluation and monitoring has to be done. Factor replacement should be immediately done. And when the patient recognizes the first sign of discomfort or trauma, he has to immediately brought to the hospital. Severe bleeds in the critical sites often have been observed that there is a repeated infusions are required and higher levels of factor replacements are to be given for 2 to 3 days or for much longer duration. The patient should be monitored continuously to check if there are any neurovascular compromise. Sometimes a fasciotomy may be required. The hemoglobin level should be checked and corrected if needed. Other measures for the regular rehab management is again RISE, that is rest, immobilization, icing and compression. So we will rest the muscle in the most comforting position, immobilize, and icing has to be applied 20 minutes for every 2 hours, and tolerable pressure bandage can be used. So considering iliopsoas bleed is the most common bleed, we'll talk about its rehab protocol. So iliopsoas muscle has a very unique presentation. The patient will come limping either on a wheelchair or unable to stand, walk with hip and knee inflection. On supine position, you will see if you try to extend the knee joint, there is so elevation, hyperextension of the spinal muscles of the spine. There will be pain in the lower abdomen, groin, or lower back pain. Pain on extension, but not on rotation of the hip joint. Paresthesia on the middle aspect of the thigh or other signs of femoral nerve compression such as loss of patellar reflex and quadriceps weakness can be noted. The symptoms may actually mimic like appendicitis. So we have to do a ultrasonography to confirm for the muscle bleed. Immediately for the management, immediately the factor correction has to be done. Sometimes we need to maintain the level for 5 to 7 days. The patient can be hospitalized for observation and control of pain. Uh, we have to, for the first week, we have to maintain a strict bed rest, and gradual ambulation with crutches can be permitted. Gradual patient's activity has to be started. We have to limit the patient activity until the pain resolves and hip extension improves. In specifically in iliopsoas bleed, the exercise program has to be carefully supervised for restoring the full activity and function, and we have to make it a point that a rebleed is not occurring. Most of the time it happens the patient is compensating from the hip or the spine, so we have to make a note of it. We have to give him a good postural training, and sometimes a traction is required to correct the deformity. And a graded traction will depend upon the tightness of the psoas and the acuteness of the bleed. So this is kind of a skin traction with posterior knee guard we use at our center. Then again, few of the splints which we make for the muscle bleed. This is the static progressive splint or the Robert Jones splint used for forearm bleed, where we do the gradual stretching of the flexors, tight flexors. A use of low thermoplastic ankle foot orthosis for resting and positioning of the muscle bleed, the calf. These are few of the protective cuffs which we advise to kids, school going kids. Headgears for the newly diagnosed infant hemophilics, elbow and knee cuffs for the school going kids and patients who travel. We give group therapy for prophylaxis patient at our daycare center. So overall, I can say that we have to keep on assessing and reassessing the patient to determine the need and demand of the exercise protocol needed for the specific patient. There is always going to be a linear assessment throughout the life, and preoperative assessment has to be done. Educating the patient and creating an awareness programs is very important. So education of the patient and family regarding the musculoskeletal complication and their treatment has to be explained. Modification of the activities that may be required after the bleeds has to be explained to the parents. School has to be made aware of the condition and what contraindication has to be explained. Along with the exercise therapy, hydrotherapy, along with the exercise therapy, hydrotherapy, heat, ice, electrical nerve stimulation, pulse diathermy, ultrasound can be used the various orthoses for pain relief and restoration of function. So to conclude, ideally prophylaxis by replacement. To conclude, prophylaxis is should can be the choice of treatment at the centers where it is available. It is the optimal way to prevent the occurrence of hemarthrosis, whereby the onset of arthropathy or can be avoided. Dosing should be individualized and increase in case of bleeding. Prevention of the bleeding episode through early treatment will prevent the accumulation of blood in the joint and subsequent inflammation and potential hemophilic arthropathy. Regular monitoring of the ROM and the ranges and the muscle strength has to be done. Clinical evaluation has to be repeated for the joints, gait, motion, muscle tone, functional level of disability, pain, and swelling. And to conclude, basically, it's a multidisciplinary team approach. So, whenever required, the patient has to be sent to the specific OPDs for the opinion, and accordingly, decision has to be made for the patient. Thank you.